Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast Studio in Fall River, Massachusetts. So today we'll be discussing women's cardiac health with Dr. Randy Averback. And before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. In Duncan Hearing Healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are greatly appreciated. So, Dr. Averback, so good to have you here today. We really appreciate you coming along and talking about this really important topic. But before we get into that, why don't you tell the audience a little bit about your background, because I think that would be important for them to know.
Sure. I've been in medicine for 38 years now, practicing. And I was probably a little older going to medicine at the age of 27 anyway. But my first college was Rhode Island School of Design in Providence. And then I was in Toronto, where I couldn't work. I had gotten married, and they had a program in art as applied to medicine.
Okay.
So the portfolio that I had from RISD, I used to go into that program, but I had to sit with the first-year medical students and compete in order to get through the program.
Oh, geez.
So after the first year, I had asked them, can I finish the Art as Applied to Medicine program, but then go on into medicine? And they offered me the position, and that's how I got there.
Oh, that's awesome.
That is so cool.
You didn't
I
have to go
love
back
that.
and do any other classes. You were able to just go forward into the program.
I needed to create the original application
Okay.
information that people would have created to apply
Right.
for medical school.
Right.
So I did that in the summer before I went back into the
That's-
second year
That's
class.
incredibly original.
Yeah, it's a little unusual.
It is. It is.
Yeah.
What was it about sitting in those classes that made you think that you wanted to go into medicine? Because it sounds like you hadn't really thought about it before.
No, I had no preparation to go into medicine before. Sitting in those medical school classes, they had some wonderful teachers. And it was particularly the anatomy class and the neuroanatomy class.
Okay.
I had a teacher that he was ambidextrous, so he would draw his diagrams for neuroanatomy with both hands at the same time.
That's amazing.
And he would say to us, don't worry, I'm going to teach you about this section and this section of the brain and this section, and about a week before the final exam, you'll understand the whole thing. And we did.
You did. That's great. Yeah, it's amazing how a good teacher can make such
Yeah.
a difference. So then you went through medical school and you ultimately decided to go into cardiology.
Yeah.
And what was it about cardiology that attracted you?
Cardiology is very challenging. It's not just a physiologic process, but it's a investigative process. Thinking when dealing with people with all kinds of cardiovascular disease, you get to help people, to intervene. There are people who are walking around because of what's happened, over these years, because of things they've said or things they've been asked. There are obviously very many other subspecialties, but some of them move a little faster than others do.
Right. Right. And cardiology moves fast. Again.
Very fast.
Yeah.
Very fast. It's been, since I started practicing, some of the most basic drugs, ACE inhibitors, beta blockers, which did not exist
Right.
to any great degree when I started, neither did echocardiogram. All of that got developed, and during all that time, I had to retrain as each new thing came along with echoes, with CTAs, with implants for ambulatory monitors. All of those things had to be retrained.
Yeah, I'm really amazed at how cardiology has just, it's advanced so much more than other fields in medicine.
Yeah.
I mean, there are others that have advanced quite a bit too, but cardiology is striking.
Yeah, it is striking.
Right? The
Yeah.
technology is amazing. I mean, think about, aortic valve replacements with TAVRs now, which
Yep.
is basically, instead of opening someone's chest open, just to do it through a catheterization. It's remarkable.
It is remarkable.
That's changed the whole face of that procedure
Yeah.
for many people.
Absolutely. And given the fact that the valve that's used, that whole procedure, without having to open the chest, was used on the sickest of patients
Right.
to start with those people that could not possibly have survived an open heart surgery,
That's another point I never thought about.
who did incredibly well. And then the use of the valve has gone to less sick people and then there's another whole set of criteria that's
Right.
come along with it.
Yeah, it's remarkable. So many new changes and
Yeah.
new developments.
Yeah.
What we wanted to really talk about today and focus on is women's health, women's cardiac health, because it's something that sometimes I think there's more knowledge about it now, but I think it's something that we forget is so important with women. It's actually probably the number one cause of death, I would think, in women.
It is.
Right.
Absolutely. It's been that way all along.
Mm-hmm.
Through the years, actually through the decades, there has been more information about breast cancer,
Right.
ovarian cancer, uterine cancer, but by far heart disease is the number one cause of killer
Right.
of women.
Right.
Mhm.
And it's obviously it's important that we have attention towards breast cancer and those other conditions, but for some reason, cardiac disease in women has never been recognized. It's more so now, but it hasn't been recognized as much as it should be. And that's why I thought it'd be really important to talk about that today.
I think it's very important to talk about it. There are some things that have changed. I mean, there are certain ways to deal with preventive measures.
Okay.
And then there are things about women that are different from those about men. Once a heart attack is present, once a stroke is present, the symptoms we should talk about a little bit because I have
Sure.
a little bit of different feeling than perhaps the typical presentation
Okay.
of what women's symptoms are. And even more importantly is how do you get someone, female or male, but female, to tell you what's actually going on
Right. So,
and come in.
so where do you want to start? Do you want to start with how the presentation might be different, or?
Sure, we can do that.
Okay.
We can do that. If we refer to the community around here, because it is different in different communities. Some have, there's a kind of joke, in certain communities around Boston, there are people that have 3 doctors for the same issue.
Right.
Here, there is very significant disease,
Absolutely.
coronary artery disease, heart attacks, valvular disease, heart failures, atrial fibrillation.
Right.
In the entire community, it's one of the most obvious, outstanding things when you come to practice here.
Absolutely. It's amazing.
Yeah. And you're dealing with a community, and I don't speak Portuguese, so there has to be a translator. But usually what happens is that there's a family member. That always amazed me, particularly in the hospital. There would be not just a female there would be a grandson,
Right.
there would be an uncle, and someone would
Yes.
come to do this to do the translation
Right.
that knew the person,
Yeah.
and I could, while I'm looking at the person, address them directly by simply asking them to repeat, and
Sure.
answer what I'm asking them, which does the best. That's the best way to get information.
Right.
Yeah, I think it's a culture that's defined by a very strong extended family.
Oh,
a
yeah.
very strong nuclear and extended family.
Yeah.
Yeah.
I mean, I was amazed, I would say maybe 7 or 8 years into my practice here, when I was working as one of the primary care cardiologists on the cardiology floor in the hospital. And we knew that the patient there was going to pass away. There was a huge family gathering. The room was full. They were kind of standing out in the hallway, and they started to sing. And the tears are coming down my face, but they started to sing as the person passed away.
Yeah, that's wonderful. It is remarkable, though, how much heart disease is in this community. I remember during my residency, I had a residency clinic like all of us did, and I didn't see any heart disease at all. I saw some hypertension, but I didn't see coronary disease or heart failure, any of that. It was a very healthy community. Hardly saw any diabetes. And then I came here, and everyone was diabetic, and everyone had heart disease, and I was astounded. It was incredible, actually.
And the better we do in taking care of it, the older everybody gets, and the more it goes on, and the worse it gets with it, and the better we do, and it's a circle.
Right. So how do women present differently with their heart disease? And I know that's a really broad question. We have coronary disease, heart failure, lots of different problems, but maybe you can talk to us a little bit about that.
If they come in, or their family brings them in, and we're speaking in English directly, they do have chest pain, they do have arm pain, they have nausea, they have fatigue, they have shortness of breath. But sometimes they tend to use words differently. So the choice of the word is different, and you get the feeling that people are trying to tell you exactly what's there, but the word chosen is different.
I've never heard that before. That's such an interesting observation.
It's how the English language is used, and that's the opportunity when you're sitting opposite them to say, can you give me another word? Can you use a different word to describe this thing? Do you feel it here? Do you feel it here? Do you feel it up here? Is it pounding? No, it's not pounding. Are you breathing heavily?
Right.
Does it occur in the same pattern, say, that angina would occur? Sometimes you realize that they're talking about pain. Or they'll say, oh, my heart is pounding. Well, their heart is pounding because there's adrenaline rush, that's there. It's an adrenergic rush. And, things are off. Either they're very hypertensive or they do have significant coronary disease, and it does need to be approached. But the sensation is described by a different word.
So in the Portuguese community, how would they describe, say, typical angina? Would it be described differently than what we usually hear, which is like pressure in the chest?
I rarely hear the word pressure.
What do you hear most?
There's some feeling, or it's sharp, and my next question will be, show me where it is. And can you give me some more words to describe what it is you feel? Does it have other feelings? Does it work its way around the chest into different locations? Does it move? How long have you had it? And I think that in order to separate out what people are really describing, and if you're looking for angina there, that's a kind of presentation that usually occurs somewhere between your nose and your belly button. It's usually on the front surface. Sometimes it's in the back between the shoulder blades there, or sometimes maybe going up the neck, but I have not heard that commonly around here.
As far as pressure.
But it's a feeling. It's the feeling that you've never had before. And you had no idea what it was when it started. And it went away. But the next day it came back, and it's in the same location. And then it starts to build. Maybe it's there twice that day. All right? Maybe you've had to slow up because you're short of breath. People will say, I'm getting old. Now, when I'm older than they are, and they tell me that they're getting old,
You're like, what?
So they may just describe it as, I can't do as much as I used to. I'm getting old.
I can't do as much. this hurts, that I just can't breathe. I'm very short of breath.
Right.
You know, doing this thing, and and can ask them, what are you not doing that you could do 6 months or a year ago?
Okay.
Can you do?
That's a great way to look at
You
it.
have great investigative skills because you like to ask people a question different ways. Like I don't hear that often, you know, and it's just really great that you do that because
That's where I get my information from.
yes.
And you have to have a lot of like cultural knowledge and
Awareness,
sensitivity and
yes.
awareness to be able to delve into this and get the answers that you're seeking.
Well, I think if you honestly, no matter who who you have in the office, male, female, young, old, somebody out of a nursing home there with their family, once you make contact, once
Yeah.
you're talking directly to the patient, eye to eye, and they acknowledge, if they can, you know, you acknowledge, and you keep doing that, even though you're getting a translation
Right.
from a family member, you just keep going, you can push them a little further.
That's so important.
Yeah.
You know?
Yeah.
When I was training, when I was at the Brigham, I did a fellowship in preventive cardiology
Yeah.
there through the Harvard School of Public Health. And one of the studies that I had worked on was to look at the data that was collected from people over 65 as to what they remembered about what happened, when it happened, what they did, what their symptoms were.
Okay.
And the significance of doing that was that they can't remember to a significant degree. They're not able to provide that data.
Right.
But if you push them in and suggest different words, or, you know, can you make the bed? Can you, who does your shopping? Who carries up the water that you're drinking
Exactly.
there? Who loads the
Exactly.
shelf, you know?
Right. So it may come out that maybe they were doing this a year ago, but now they just
Exactly.
can't. Things of that nature.
Exactly.
Okay.
You know, you were talking a little bit about one day they'll have a little bit of pain, the next day they might have a little bit more twice a day instead of the once a day.
Yeah.
Is there like a telltale sign that you're not like, oh, I must be overtired, or like something that you can't kind of justify away?
Well, a lot of people will justify because they
Yes,
don't want to come in,
exactly. Yeah.
and because of the possibility of something terrible happening, which is when they should be in anyway.
Right.
Right.
There's a lot of rationalization that goes
Oh,
on.
yeah.
We see that. We've seen that. A lot of
Well,
our
yeah.
guests have talked about
But
that.
like, you know, I think I pulled a muscle, I was weeding or something like
Yeah.
that, versus like, oh my God,
you want to
know.
think of the more benign cause for your symptoms. That's human nature.
Yeah. The thing is that if they come in with that, that's terrific.
Right.
Then you can work with it and you can figure it out.
Right.
But if they don't come in with it,
Yeah.
you know, or stay out or think it's reflux, which I'm sure you've talked about before, or they've used the local physician, Dr. Google.
Right.
Yes.
Right.
You know, the problem with Dr. Google is that they don't know where they fit
Right.
in the diagnosis that they think it is.
Right.
They don't know, is it severe? Is it mild? Do they have a piece of this or a piece? Because some of the symptoms cross diseases.
Right.
And-
And it's true. And like, for example, with side effects, often patients will, they'll look at that, but they don't know how specific or how common that side effect is. It doesn't
Exactly.
tell them that.
And it doesn't account for individuality.
And I have a lot of
you know?
patients who just don't take the meds because they read that it could cause this,
Exactly.
that, and the other thing, which is really quite uncommon. But
Because they think it's 50-50. Maybe
Right,
yes, maybe
right,
no.
right,
But
right.
anything that's even reasonably close to that isn't going to make it onto the
Right.
market.
Right.
Dr. Averback, if someone is having a heart attack, they've called 911, the ambulance is coming at home.
Yeah.
Is there something that they should do? Like, are they still taking that, like chewing an aspirin? Like,
Not as much.
okay.
No, it's not thought of in the same way. There are some things about use of aspirin with women and cardiovascular disease, and statins, and either heading off the effects of disease or secondary MIs. or anticoagulation that are different from men, and they're certainly different than they were 20 years ago.
Okay.
Okay.
Well, I'd like to talk about that, but I'm also still curious about, we talked a bit about the Portuguese community, but just
Yeah.
women in general, do they present differently than men for some of these conditions?
Not completely
Okay.
differently. There's an overlap, and it really depends upon, to some degree, the community, their personalities,
Okay.
their age, their family, what they're responsible for, what they think their role is supposed to be. Are they supposed to come in, or are they just supposed to be
Well, that's a
stalwart?
question. Do they come in later? Because
Yeah,
they
they do.
tend to be stoic more than men.
Around here, they do. Although I've met some pretty stoic men.
Right, right,
know?
right.
For instance, there was a patient that I had maybe 6 months ago.
Okay.
She's a lady in her 80s and very active lady, very with it, very sharp. And she was visiting on one of the islands. I don't know if she was on Martha's Vineyard or she was on one of those. And she was visiting, I think, her sister. And she didn't tell her sister that she didn't feel great, but she
Okay.
finally came off the island. And the next day after she came off the island, she came in acutely to the hospital, had a large MI, and really compromised about half of her heart muscle. Had she not come off, it would have been a disaster because
Right.
there was no care there that was adequate to
Right.
deal with what
Right.
happened. And she went immediately to the cath lab and had to have a stent placed.
Sure.
But she had also thought about that she's just slowing down.
Yeah.
And she wasn't feeling great. And she had something in her chest, and there's a lot of somethings.
So it's not that necessarily women present completely differently, but they maybe don't come in early enough sometimes.
Sometimes they come in later. Their disease can be worse when they do show up.
Okay. Because they've waited.
They've waited.
Yeah.
The degree, you do the heart catheterization, and the degree of disease and vessel involvement there can be more, certainly. And some of the outcomes afterwards with heart failure are worse for women. In addition, issues like stroke, also worse for women.
Is
We-
that
I was-
is that because of the correlation of them coming in not soon enough, or is that a correlation because women's outcomes are, given the same set of circumstances, are just different from men's?
I think women's
outcomes.
outcomes are different from men. It's not that some people get there, and there's a very strict definition of when you can go to the lab and when they can thrombolize something or
Yes.
clear, just like there is for pulmonary embolus.
Sure.
I don't think that there is a strict difference between what women do and what men do
Okay.
in that way.
We did have recently a vascular specialist on who was saying in women it was different because the caliber of the blood vessels
yeah.
was different, and that was a major issue also.
Yeah, because women theoretically are a little smaller, okay? And thus the caliber of the vessel is a little smaller. And when you get down to trying to put a stent into a vessel that size of which is 2 millimeters, 2.5 millimeters, you don't have good flow there, and you can't rely on that,
Right.
and sometimes you can't get there.
Does the smaller vessel occlude more abruptly in some cases?
The flow won't be, the TIMI 3 flow,
Right.
it just won't be
Okay.
there. And then when you go ahead and you do the cath and you look at where the important flows are coming from to supply that heart muscle, it may be so small you can't get there.
I see. And you had mentioned the medications they function differently in some way, I guess you had mentioned. There's some differences in.
There are some, well, the basic one and for certain medications is the fact that women can get pregnant. I mean, women
Right.
have right through all of those years when you're not just taking care of coronary artery disease, you are taking care of hypertension
Right.
and hyperlipidemia and all of that, and then there's a pregnancy on top of it. And then
It's tricky.
yeah, and there are diseases like lupus and rheumatoid arthritis, which
Right.
are particularly relevant for women.
Right.
What you can use, what you can't use, and those very different.
And those diseases increase the risk of coronary artery
Yes,
disease
they
also.
do. Hmm.
Yeah, interesting.
Very much so.
What are the major diagnoses that you've dealt with in the community?
For
Women's cardiac health.
all kinds.
There's no like top three. It's just like across the spectrum.
I'm in my practice, I've seen women come in with multi-vessel coronary disease at the age of 36 and have to go to bypass.
Is that lifestyle or familial?
That's genetic.
Yeah, that has to be genetic.
That is genetic. The risk in having first-degree relative who died young, had severe hyperlipidemia, certain kinds of hyperlipidemia, that's genetic.
For our audience, the definition of first-degree relative.
Mother, father, brother, sister.
Mm-hmm.
Right in that nuclear family.
Absolutely, right in the nuclear family. And the people talk about, I have heart disease in my family. And what really begins to show is when it occurred in that first-degree relative less than 50 years old,
Okay.
you know?
Okay.
Yeah.
So when they were
And less
first
than
diagnosed with
55,
something.
Or they died.
Okay.
They died.
Okay.
If they were diagnosed at that time, but they lived to 85,
That's different.
that's different.
Okay.
Yeah.
Exactly.
Okay.
But if they died when they were young, or
Then
there
that's a
was an
problem.
uncle or a brother or two of them, same side of the family, that had that happen when they were younger, had sudden death, that's a whole different genetic.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
Dr. Averback, this is like a truly broad stroke question based on what you were just saying. So if like my mom and my dad, or both of them for that matter, died at like 55 with cardiac disease, is there a chance I can live to 85? Is that dependent on it specifically what was going on with them? Or can you save me so I can live to 85?
We can investigate you to start
Okay.
with. You take a look at where you are now. You've got a mix of genes there. Who knows what you got? Do you have
Right.
brothers and sisters?
Yeah. And, but suppose like I'm just scared. I'm like, all right, I want to do something,
Okay.
And it's, so you just go down that line of questioning and,
So I would start there. There are things about which you can do something, and which are all the preventative things typically that we talk about.
right.
And there are the genetics, whether you have that or not, you don't know. You may live to be 95.
Okay,
You
good
know?
to know.
But you can look, if you want to look at your cholesterol, it's not just one number. We can look at you and do what's called a CAC score, coronary
yeah.
artery calcium score,
Right.
which is probably the most predictive way to look at any of it, because there's nothing about an echo or a stress test that predicts anything.
Okay. Yeah.
Those things tell you what there is at the time that you do it, and then you put
Yes.
people's symptoms with it, and you
Right.
go from there.
And
You
get
could
that
have
full
a
picture.
65% occlusion and still do well on a stress test.
Absolutely.
And that's what it's hard for some patients to fathom.
Yeah, absolutely. And the longer you have that occlusion, or inclusions
good point, too.
involving different vessels, the more collateralization gets going, and all the small vessels grow from the right to the left and left to the right, and people never know it.
Yeah, your blood finds those country roads to go down instead of the
certainly
highway.
does. And those are people that no one may want to intervene upon with stenting, because what's there is really a prominent bridge and important.
Right.
So if you take away the bridge or you put a stent in it and it closes, you've made more of a problem rather than less of a problem.
Right.
If you think of all the risk factors that people have, whether it be men or women, what do you think the most important one is? Is it genetics? Is it smoking? Is it diabetes, high cholesterol?
I think just in terms of frequency, it will be smoking and diabetes.
Yeah, and you put those
And
two together, and
hypertension.
we've heard this before. You put both of those together, and it's smoking and diabetes.
Yeah.
It's just a horrible increase in risk.
Yeah.
Yeah.
The other thing, particularly for women, is that if you have hypertension before you have a baby, you have preeclampsia, or you develop hypertension and it persists more than 20 weeks after you deliver the child, the risk of having an increase in cardiac disease is significant. So there's a lot that happens in there. There's also things that happen with coronary artery dissection more with women that happen less with men.
Why?
It may be the endothelial dysfunction. It may be the size. I don't know if there's an absolute answer to that. In my experience, there was a 40-year-old female that came in, and she had terrible, out-of-control blood pressure. This was 200 over 100 and something.
Bad.
And she had a aortic dissection that went from her aortic valve all the way around, all the way down to her legs, down into her right leg, and into some of the GI vessels. It was.
Did you break out in a sweat when you saw that? Like, what do you do with that?
You go directly to a surgeon.
Right.
My God, what was the
Quickly.
outcome with her?
Yeah, I mean, that's so extensive. Were they able to repair that?
Yes.
Really?
She
So-
comes to see. She comes to see
Really?
the patient. Yes, and she knows
Oh my
that
gosh.
she can't fool around with blood pressure control or
Absolutely.
body weight or diabetes. She, she was very fortunate.
Oh my God.
Right?
Incredibly.
Incredibly, is right.
Dr. Averback, just looking at some of the lectures that you've given and stuff, which is like 20,000. One of them is menopause and cardiovascular disease, and I know this could be a whole other podcast. But
Yeah.
just like, what are the main concerns after a woman goes through menopause?
Well, typically, when we first started looking at all of this stuff, you no longer have an estrogen-progesterone cycle. You no longer have that level of protection that made people think all those years ago that women never got coronary artery disease.
Yeah.
Right.
They just didn't get it.
Yeah.
Why? Because they didn't get it as early as men. And the average age of menopause, I think, is 51
Right.
at this point. But some women get, very less than 40. And
Right.
some women go to almost 60
Yeah.
with that. But once that cycle is gone, the protective component of that is gone. Typically, your LDL is going to start to rise. Your HDL may not change at all, and it probably isn't going to change no matter what you do at this point in time, because we don't have fabulous agents to push that thing up.
Yeah,
Right.
for HDL, sure.
Right.
Yeah, but we can deal with body weights to change things. We can deal with exercise to hopefully change things. But the inside physiology and the ability of the vessels, the arteries, to distend, to contract, to function normally, changes along with age and along with losing the estrogen progesterone. Not happy news.
No, I don't like that. You have an advantage. So something else that caught my attention is an article, The Effects of Dietary versus Drug Intervention on Vascular Reactivity.
It was an older look
Okay.
Vascular reactivity, it's a bona fide issue.
Okay.
I can't speak tremendously to the difference, what makes it more
Yeah, yeah.
significant or less significant.
Okay. All right. I was just curious that it would be studied, like, because when you think of dietary versus drug interventions, you're like, don't the drugs win every time?
No. Not always.
No, no. That's interesting to me.
My feeling is that one of the major things, if you look at different communities,
Yeah.
body weight has risen astronomically,
Right.
True.
and it's not just whether the community smokes or not,
Yep.
or is active or not,
True.
Right.
but what's in food and what we think is in food and what we weigh, unbelievably different from what it was from our parents' time.
Yes.
You know?
Yes. Absolutely.
Frozen foods and fast foods, and it just
Yeah.
gets worse and worse and worse
Yeah.
as you go through.
Right.
And the result of having a significant amount of weight produces worsening hypertension, worsening lipids, diabetes type 2. It does a job on your joints,
Right.
on your knees, on your feet, on your hips.
So true.
It predisposes for some people, because they can't stand up or balance as well.
Right.
They are unable to really mobilize themselves
Right.
in
Right,
very
right.
simple things. It would be impossible to say to that person, well, you need to lose weight, and so you get up and walk a mile. Can't happen that way.
Right.
No.
Because they haven't walked a mile in 10 years.
Exactly.
True.
So, I've seen you done some work with the bariatric population as well.
Mm-hmm.
So there are some interventions and things that might be contraindicated with the bariatric population that's commonly used in the cardiac universe. I'm thinking of like baby aspirins or things like that.
In what way?
So I had bariatric surgery. I'm going to talk about myself for a minute,
That's
Chris.
okay.
I had bariatric
Yeah.
surgery in 2011.
Yep.
And they are very strong on you can never, ever, ever take Motrin or aspirins or baby aspirins in any type of form.
Yeah.
And my surgery was 14 years ago, and I drifted away from that a little bit. My mom had a stroke. I got scared, and I started taking a baby aspirin, and boom, got an ulcer. So instead of, what happens then? So if I develop cardiac disease, this has always kind of worried me a little bit. I don't have that in my toolkit.
Yeah, right.
It's
know?
not that you don't absolutely have it, because if you had to have a stent and they had to use, and you were using aspirin typically, clopidogrel or Plavix or any one of them, you'd have to be very careful about when you took their medications,
Okay.
what was the relationship to food, to the meals,
Okay.
because then with a change in the anatomy,
Yeah.
even without the surgery, that pill goes down the esophagus, and it lands in the same place, roughly, on your stomach lining every time you do that.
Okay.
But if you don't let it land on your stomach lining, and you take this thing after you eat, and it
Okay.
lands on food, gets
It's a
turned
little bit
around, and
better.
eventually goes on down, in all likelihood, you'd be able
I still
to.
have it in my toolkit.
Yes, you do.
All right.
Just got to be more cautious, take it a certain way.
Much more so, yeah. And see what happens from from the GI point of view. Do you need to use omeprazole? Do you need to use
Right.
some kind of gastric acid reduce protocol?
Right.
Do you have fruit juice acids that do that, or does that have to be modified too?
Okay.
Plus, I know that when you have gastric surgery, your ability to absorb sometimes the other
Right.
vitamins, minerals, and
Right.
things, you have to be very careful with what
Right.
you're doing.
Right.
Yeah.
Exactly. So we talked a little bit about the cardiac risk factors and people that develop the cardiac disease. Is it reversible up to a point? Like if you've been a bad boy and now you're 40 and your diet isn't good, your exercise level isn't good, you've done some damage,
You're a smoker,
you're a
maybe,
smoker,
diabetic.
exactly. Like, can you turn that around and start from ground zero again?
And I don't know that you can start from ground zero.
Maybe the second floor.
Because you can't grow new lung tissue
Yeah.
if you've smoked,
Right,
2 packs
right.
a day
Right.
to do that. However, you can lose weight, you can control blood pressure, you can stop smoking. I've seen you stop drinking, incredible things happen. Sometimes it takes the heart attack to
Scary. Yeah.
bring it to reality where people
Yes.
say, all right, that's it. I want to be on this earth a whole lot longer
Right.
than this is going to allow me to do. And sometimes the spouse is very helpful too.
Sure.
He or she will say, that's it. We're not doing this anymore.
Right.
Shape up, buddy.
Yeah. And they do.
Of course.
It depends on the individual and their own intention and drive to maintain it.
Right.
And
Yes, it can
sometimes
be
you'll do something for someone you love more so than you'll do it for yourself. If like your husband's very scared or your wife
Yeah.
is very scared, you don't want them to feel that way.
No, just
So-
depends how the two of you are set up
Right.
Yeah.
to do that. For most people, and people that are single, it really is a decision you make with yourself. It's a discussion. I've said to people, look, you weigh 350 pounds, and and I know that there are certain things that you could do here that would be so helpful, and I'm sure that you've heard it, for the last 10 years. Exactly, do this, do this, do this, do this, but you can't manage to do it. And the bottom line is that they need to have a discussion. Go and look in the mirror and discuss it with yourself. Can you do this? Do you want to do this? It's not that I can make a decision for you. I can tell you what to do. Sometimes I can help you think about it, how you could approach it that, doesn't go off on some diet that you've heard other people do that
Right.
doesn't work.
Right.
And you can't do it either because that's not how the body works.
And sometimes it's overwhelming too to know you have to get rid of doing 6 things that aren't healthy. Doing one thing is better than doing no things. And that one thing, once you get that nailed, then move on to the next thing. And eventually,
Yeah.
you'll get there depending on how bad your
Sometimes-
situation is.
Yeah. Sometimes people, they start in one place, not thinking that they can pull it off,
Right.
Yes.
and they do it.
yes.
And they say, if I can do that, then I can do that because it's the
Yes.
same thing that's going on
Right.
Right.
and they work
Exactly.
from one to the other.
I should have shown this earlier. I think we should show this, though, don't you think? This is really great.
I love it.
Yeah. We'll show it to the camera. So this was done to recognize Dr. Averback in Beth Israel Deaconess Hospital, Needham campus, for participating in the Boston Heart Party 2003. In doing so, 4,961 women and men received a free screening for cardiovascular disease. That's great.
And that's where we started
That's where you started.
all those years ago.
All those years ago, right? And we've come so far.
Yeah, and the Red Dress campaign, it's the second Friday in February is the day to celebrate that one.
Right.
Going to RISD, I'd love to see some of your red outfits that you wore.
My red outfits, I have plenty of red drawings. Let me
drawings.
tell you.
So, you had mentioned screening when you were talking through the award, Chris. And
Yes.
the screening, is it different for men and women? I guess on a specialist level, and Chris, also with you, when you're doing, is it the standards, are they a little different for
You
men
mean
and
for
women?
cardiovascular disease?
Yeah, just like the regular screenings,
Well, I don't know if Dr. Averback will have a different answer. For me, as a primary care doctor, it's the same, but I don't know
Yeah.
if it's different for you.
No, it starts in the same way, unless there are special circumstances, like you have someone who's postpartum.
Okay.
If you're within 3 months postpartum, And there's any question of diabetes or hypertension, you want to take a look for other possibilities like postpartum cardiomyopathy, particularly if they come in and they're short of breath, they can't quite keep up, they're not recovering as expected, because that has a meaning for whether they'll ever have another child.
Right. Is there something that's coming down the pike in the cardiovascular world that you are just super excited about? Or have there been things in development that you're like, gosh, I can't wait till this gets here?
There is so much that touches so many different areas between valvular disease. There's a huge amount coming down in mitral valve disease,
I've heard that.
which no one has touched for a very long time. You know, there's no devices or particular.
Right.
Way if you go back 2 decades, there was cath, there was all kinds of surgery,
Right.
but the mitral valve was just found to be something all by itself. It's not the same anatomy as the aortic valve. It's set up different. The concept of mitral valve prolapse, when you have, that's all changed. But when you have a lot of mitral regurgitation, and on the opposite side, the right side of the heart, at the same level, you have a tricuspid valve. And if that doesn't close adequately, the pressure in the lungs rises from both sides, and you have a whole different day for an individual when they've got big pressure, intracardiac and intra-lung pressure.
Right.
So they have to be treated in a different way.
So there's definitely some new things coming around the bend
Oh, yeah.
for valvular disease, which
Yeah.
is exciting. I mean, we talked about aortic valve disease earlier, and
Yeah.
it'll be nice to have something for mitral valve disease
It will be
similar to a TAVR.
absolutely. When, there are even procedures that are done. Rarely pulmonary valve is worked on in any way. Sometimes the tricuspid valve is. Sometimes you use the pulmonary valve to replace a tricuspid valve. It's not common, but you can. But there's so much that's changing. And then you go to the mitral valve and you have mitral clips, and you have the ability to clip off or obstruct the area of the heart that allows the little clots in atrial
Yep.
fibrillation to be made, and potentially obviate the use of anticoagulants for people. It's all cardiac
So exciting.
stuff.
I have a kind of weird question for you now.
What's weird? Nothing's weird.
What happens when the diagnostic test doesn't match the symptoms that they're having and you're like, I can't believe this was negative? Or like someone, who's been having they're like, I've been having this weird things happen inside me. I know my heart's like tripping out, but they wore a Holter monitor for a couple of days and nothing shows up. Or, just like there's a mismatch with what they're saying and then what you're seeing diagnostically.
Yeah, the answer to that is that there are mismatches in complaint of chest things with echoes, with stress testing, with stress echoes. None of these techniques is perfect. You get to about 85% sensitivity and specificity with nuclear stress testing. If your person is going to walk on the treadmill, they have to have their heart rate up to 85% of their predicted maximal rate. Otherwise, I can't do a real interpretation. If I see all kinds of rhythms that come up, ventricular rhythms, or they all of a sudden go into atrial fibrillation when they're doing that stuff, then we're off to the electricians.
Sure.
And I know you interviewed Dr. Sood.
Right.
And, the other part of the electrical abnormalities is something that I've learned to do maybe 5-6 years ago. When you put an ambulatory or a Holter monitor on somebody for 2 days, 2 weeks, even a month, and nothing happens out of the ordinary, that doesn't mean there isn't anything.
Okay.
It just means that in that period
didn't
of
catch it.
time, it didn't show.
Okay.
And sometimes people do They're very intermittent. They're correct. They pick up what's going on, but they're very intermittent, and you wouldn't have been in the right time or space to do that. That's where the subcutaneous monitor comes in. We put that under the skin.
That's an amazing development right there.
Oh, that's
Can you talk a
Total.
little bit about that?
sure. That is a device that is much easier, I think, and much more effective. At 1 year after the device is placed, they have found AFib and results into the 2-year sequence because people are really maybe stretched out. But if you wake up with a stroke one day because of AFib, life is very different.
Sure.
Exactly.
But these things are done right in the office. It's the size of it's like a matchstick, you know? It's
Really?
just put
Yeah.
right underneath into the subcutaneous tissue in the chest, and it monitors your
Yeah.
rhythm for years.
Wow.
About 2 years or so?
A good 3.5,
Three
and
and a
the
half?
second generation is over 4 years.
Wow.
The thing is that by the time you've gotten out that far, if you haven't found anything, and you're not getting into a whole different age group where
Right,
you might
right.
suspect it,
Yeah.
you can choose to leave it in place. You do not have to explant. Take
Nice.
that thing out. It's about the size of a paperclip.
Yeah.
Nice.
Tiny.
And
Oh,
it,
I love that.
I put in hundreds at this
Yeah.
point.
Yeah.
And we fit it to the right place. You take a look at the rib cage, how low it is, where the heart is likely to be, how big the person is, where the depth to which it needs to sit, and you look at the recommendations from the company that has produced the device. You freeze the area. It's a tiny incision. It slides right in under the skin, and then you use human glue, just like when you're bypassing, in your chest.
Yes. Yes.
It disappears from view.
Nice. Love
For
that.
women, they have to go, if they're going to have a mammography, and make sure that the technician knows that what that
Right.
little thing is in there and not trying to
Exactly.
squish it on the end to end. But
Ouch.
most of the places are very
They're-
now.
they're
Yeah,
versed
they're
in
up
what to
on
do.
what that is,
Yeah.
what they can do. You can go
Nice.
through TSA with that. It's not affected by anything else.
That's great.
It doesn't have wires. It's not telling you what to do. It's only collecting information. And it's wireless, and you have a device. You're either using your phone or there's a collection box and transmitter by your bed at night. So when you're sleeping, it empties what the recorder picked up during the day and sends it to my office.
Suppose you have a very alarming rhythm. Does it notify anybody?
It will come in, and there's a designated person in the office
Okay.
who is responsible for this.
Okay.
And I look through everybody's
Okay.
periodically. But what I tell people is that if you have an event, they've come in, I passed out on the road. Somebody else had to grab the wheel when I was
wow.
driving. They can't drive now, but if they're passing out, when you come, wake up from that, call into the office or have your family call in, give us the time, what happened, and we'll go chase it down.
Nice.
Mm-hmm.
Love that.
All right.
Good.
It's great.
Yeah.
It's very good. Is there any one message you want to leave our audience today?
Talk to your patient,
Right?
ask a bunch of questions,
Exactly.
because it's not going to be in the electronic medical record reliably. They don't remember it reliably. They're family members that weren't with them during that time of their lives. Poke at it, because the older people get, and lots of women don't want to talk to you.
Right.
If the men come in there,
Exactly.
they'll usually tell you something's wrong,
Yeah.
but the women may not want to talk to you and see what it is. They're in there for a reason.
Right. And don't wait too long to come in.
Don't wait. And if you can make contact, then it becomes, believe it or not, a pleasure to come in.
Mm-hmm.
It's you could call it a social visit, but by the by, you're checking medications
Sure.
and you're seeing, is something else needed in order
Sure.
to make life feel better,
Nice. Very nice.
Well, thank you so much for coming in today.
You're
Really
welcome.
appreciate it. It was very informative.
This
It
was fun, great fun,
Yeah, it
and
was a
I
great,
hope so.
great talk, and I think it was very educational
Okay.
So great. And I want to thank everyone for listening to our show. If you'd like to become a sponsor, contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music. Primacare, your trusted medical providers in southeastern New England, and the BioSkills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And of course, thank you, Dr. Averback, once again for being part of our show.
Thank you for
Appreciate it
asking me.
greatly.
Very much.
Yeah.